Hello, my name is Ian McCall, and this is the first of the Ken Paver tutorials in dermatology. I think these will be most of use to registrars who are in their third and fourth years. You need to have a fair understanding of skin disease to get the most out of these. Ken Paver was a dermatologist who I had the privilege of training under at Skin and Cancer Foundation. He used to take us to his home on a Tuesday night. There was about four of his registrars at the time. And Ken would go over a variety of topics. I sort of recorded some of these at the time and wrote up some notes. And these tutorials are based on the notes with additional information that I've added in. I think they're correct. If you find mistakes in them, then certainly email me and let me know. Now, what were the topics in this particular tutorial that Ken went over? Well, we're going to look at erythematous plaques in the cheeks. We're going to look at the DD of congenital oral leukoplakias. Then a bit on lumps in the gums, the histiocytic syndromes, and then some questions on each of these conditions here. Now, if you're very early in your training, some of these won't mean anything to you at all, but, you know, a lot of dermatology you get just by immersion, just by looking and hearing people talking about things, and if it happens several times, you build up links in your brain, and at some time in the future, you may see one of these, and hopefully a few things will fire. Let's start with congenital oral leukoplakias. Now, congenital oral leukoplakias, that means they're in the inside of the mouth at birth. And what are the things that you look for? There's the white sponge nevus, there's Papillomavirus congenita, keratosis congenita, Darriers, and hereditary benign intraepithelial keratosis. All right, all of them are exceedingly rare. Let's have a look at them in turn. What about a white sponge nevus? This lesion is going to be usually on the buccal surface on the floor of the mouth. You very rarely get this on the tongue itself. All right, and basically you're just going to have this white edematous area over the buccal mucosa. Now, it's inherited as an autosomal dominant. HPV, Papillomavirus 16 DNA has been identified in some patients. But look at this thing, paradoxically, tetracycline antibiotics improve some cases. And these lesions, similar sort of lesions, can be found in the mouth, the vagina, and the rectum. Papillomavirus congenita. You know, whenever anyone mentions that name to me, the first thing I think about are the great big thick nails that they have. You know, gross hypertrophy of the nails. So thick nails are the main things you think of. Palmoplantar keratoderma, they should develop as well. Follicular keratoses at the knees and the elbows. Occasional blisters. Palmar and plantar hyperhidrosis. And this leukokeratosis of the mucous membranes that we're talking about just now, one of the congenital oral leukoplakias. Again, it's inherited as an autosomal dominant, but you get autosomal recessive forms. And let's have a quick look at this link that we've given here. Yeah, you know, these are what's mainly showing you the nails in this. It's not showing you any of the oral things, but just look at these nails. Let's just have a quick look at this picture. You know, that's the sort of thickening of the nails that you get in Papillomavirus congenita. There's just nothing else quite like it. Okay, so what's the other one? Keratosis congenita. Now, in keratosis congenita, they may seem something similar, but they have thin nails. And they also get a reticulate pigmentation of the back and the neck, and they get some atrophy of the skin too. And they also have ectodermal and mesodermal changes. And this reticulated pigmentation that they get may follow the lines of Blaschko. But they have this oral white areas as well, and it can involve the tongue as well as the buccal mucosa. Then there's this condition, hereditary benign intraepithelial keratosis, and it's associated with pingiculae. Now, pingiculae are they're little areas of proliferation of telangiectasia and the like, usually on the medial surface of the eye. They're like a pterygium, but there are some subtle differences. You don't expect that in younger patients anyway. And then there's Darier's disease, an autosomal dominant, greasy papules, usually seen obviously in the sebaceous areas, particularly behind the ears, the anterior chest wall. But some cases of Darier's, they'll have small white papules on the gingival palate, and pebbly areas with verrucous white plaques will be seen there as well. Now I'm just going to quickly flick into this article because it's got some lovely pictures here. So let's have a quick look at them. We need to download it. Bear with me. Shouldn't take too long. But there are some nice pictures in here. This is a dental article that I came across. How did white oral lesions, how to distinguish the benign from the deadly. Let's just look at the pictures. By a guy called William Lawson, the Mount Sinai School of Medicine. Okay, that's his little table of white oral lesions. We'll come to, these are the genetic ones that we're interested in. We'll come to some of these later on, but it's the genetic ones we're interested in just now. Darier's disease, Pachyonychia congenita, disc keratosis congenita, white sponge nevus, benign intraepithelial disc keratosis. So let's look at them. What's this one here? That's just leukokeratosis. You got a biopsy it. This was an SCC when wanting to get to the congenital ones. Bear with me while I flick down to them. Okay, that's lichen planus. Don't want that. Sorry, here we go. Genetic disorders. Okay, there's the white sponge nevus. Now, again, buccal mucosa, you can see that area in here on that buccal surface, and the changes of disc keratosis within it. And then, see what other examples we have. Yeah, there's a patient with Darier-White disease, and this is Darier's syndrome. They're saying, although it has a predilection for the buccal mucosa, lesions can also occur in the palate. That's just candidiasis. I mean, you might see that on a congenital basis. It's a really thick candidiasis, so look how thick that is over the soft and hard palate. I thought we had some better pictures than that for some of the others, but the white sponge nevus was the thing I wanted. At least they had a picture of that. Bear with me. Next thing we're going to look at are the histiocytosis syndromes. Now, let me show you a picture first of all. This was an elderly lady we saw in St. Vincent's a long time ago, and she presented with this submammary type lash with a lot of pink papules peripherally here. But the other thing she was presenting with were these bleeding areas. There was some hemorrhage into the skin. Now, some of these papules here were keratotic, so they were red and scaly. And the initial clinical impression was that she might have had Darier's disease. But we should have been able to tell from the history that she should have got that a lot earlier. But morphologically, that's what it looked like. But this was acquired, and when these were biopsied, she was in fact shown to have a histiocytosis. Now, the histiocytoses are divided into those that are due to Langerhans cells and the others. And histiocytosis X was a term given by, I need to get the details again, of someone, I think back in the 50s, when the cause of the condition wasn't known, and it subsequently was found to be a proliferation of Langerhans cells. Now remember, Langerhans cells are these dendritic cells that are found in the epidermis that normally process antigen in the skin, macrophage it, take it to the local lymph nodes, present it to helper T cells, and you develop your immune responses. So it seems to be it's almost like a type of autoimmune disease. There's the acute disseminated form that was called the leprous seaweed disease. There's the chronic progressive Hanschula Christian, and the benign localized variant was the eosinophilic granuloma. These histiocytes, as well as being found in the skin, they have a predilection for bone as well, and they'll present with bone cysts. So you usually have to do x-rays in patients to see if they get any signs of bone cysts if you're expecting this. And there's a variant that you'll see in adults that will involve the lungs, particularly in cigarette smokers, around the bronchioli, and often it'll just be there without much in the way of proliferation of cells in the skin. There are the non-Langerhans cells, histiocytosis as well, and these are known as xanthoma disseminatum. Diffuse plain xanthomatosis. These patients will present with yellow plaques on the palms of the hands, often involving the creases. Juvenile xanthogranuloma, we'll see an example of this shortly. They can present in younger children, usually as solitary, sometimes multiple yellow papules, particularly in the face. And there's this other condition, benign cephalic histiocytosis. These lesions generally present in children in the first couple of years of life. They are papules, sometimes slightly scaly on the face, and they will resolve spontaneously. We've said they're really most commonly seen in children less than 6 months of age, and they clear with time. So let's have a quick look at this derm atlas one on a histiocytosis. Sorry, I should have had the link in there. Let's put it in. See what comes up. Histiocytosis X can present in children as solitary lesions like this, solitary nodules, or as in the more diffuse form like this child here. And it's very difficult to make this sort of diagnosis. They've commented here they were hemorrhagic crusty papular eruption, but they had a lymphadenopathy and a ganomegaly as well. And the skin biopsy showed the changes of Langerhans cells histiocytosis. Often you'll find these papules are more concentrated though in the anterior chest and sometimes in the face in the more seborrheic areas. So not a common condition. You generally need a biopsy for it, but if you've got a lesion that's it's very seborrheic-like, even sometimes you might try and diagnose it in a child. You might diagnose it as severe seborrheic dermatitis. Then consider that it might be a histiocytosis, leprous seaweed disease. We won't bother looking at all these others. You can go in and have a look at that yourself. Okay. What about erythematous plaques on the cheeks? You know, red plaques on the cheeks. First thing you look to see is if they're scaly or non-scaly. If they're scaly plaques on the cheek, then, and if they're multiple, then look at your mnemonic of the PM's PET or petal, PET, psoriasis, eczema, or tinea. You certainly don't expect psoriasis much in the face. You might get it on the scalp margins. Eczema, again, you can get just an erythematous plaque of eczema on the face, but it's not common, usually in other areas. Tinea, sure, you can get tinea on the face. Anything that's red and scaly on the face, you've got to consider that it's tinea because it may have had steroids applied to it, which would reduce the degree of scale anyway. Annular erythemas, not often on the face. EAC is usually elsewhere. And L for lupus or lichen planus. There's lichen planus actinicus, which can occur in the face, but it's usually seen in adults rather than children. It has a curious area of pallor around the lesion. But lupus certainly can occur in the face and be a red, scaly plaque. But let's look at some of the others that I've mentioned here. Lupus, Jesnos lymphocytic infiltrate. This again is probably a form of subacute lupus. It'll present as a red, usually a non-scaly plaque on the face. Polymorphous light eruption. Granuloma faciale. Again, one or two nodules, usually on the central part of the face rather than the periphery. And they usually have a surface that looks like orange peel. It can be pink, it can be purple in color. Lymphocytoma cutis, again very similar. It's often difficult to distinguish these two and you need to do biopsies. This is usually a benign process resulting from insect bite reactions. I remember I had one of these when I was at the Skin and Cancer Foundation, and Steve, we got a biopsy. Amelia Doherty did a biopsy on it for me at the time, and it was added to Steve Cossard's little collection of good cases that he had for the registrars to look at. Erysipelas, again, it's usually a solitary plaque, painful because it's a streptococcal infection. Sweet syndrome, neutrophilic infiltrate, sure, that can certainly occur on the face, and there can be a degree of edema in this as well. Occasionally, even tiny little pustules within a plaque of Sweet syndrome. MF, T-cell lymphoma, certainly can give you a red plaque on the cheeks with T-cells infiltrating the epidermis. Leprosy, usually the more peripheral areas, the cold areas of the body rather than the warm areas of the body. Cold injury in the cheeks, sure, a form of severe fat injury, fat damage, paniculitis from cold. Amyloidosis, not common to give you an erythematous plaque in the cheek. Usually there's a bit of hemorrhage associated with amyloid because it's deposited around the vessels and makes the vessels unstable and they bleed. And lichen myxedematosus, seen in, it's usually seen in people who have or may subsequently develop a myeloma protein. But again, this usually will give papules generally on the arms or legs. Pretibial myxedema can be a form of this. What about Jesner's lymphocytic infiltrate? Usually on the peripheral face. I said, for instance, that granuloma faciale was more the central part of the face, whereas a Jesner's, if you're going to get it, is usually on the peripheral face, usually in older males, forehead and cheeks, central clearing. Made up of polyclonal T cells. There's often, in fact, some mucin in these as well. Lymphocytoma cutis, central face, similar to granuloma faciale. The nose, sometimes the earlobes. The earlobes are a curious area for lymphocytoma cutis, but you'll see various pictures of that, usually in young adults. Again, your congregation of lymphocytes is generally going to be in the dermis itself, but they're polyclonal. If it was a B-cell lymphoma or the like, then there would be monoclonal T cells. It was said histologically usually B cells around lymphoid follicles. And then granular faciale, I said that again was central face, nose and cheeks, single and multiple, that peau d'orange appearance, slow growing. From skin color through to purple. And it's a granulomatous infiltrate with leukocytoclastic vasculitis. There's usually another characteristic feature is histologically is that you get a Gren zone. In other words, there's an area between the epidermis and the dermis that's free of inflammation when you have a look. This photo here showed some early discoid lupus. Now there's not a lot of scale there. You've just got a red, slightly infiltrated series of small infiltrated plaques on the face here. It'd be tough to make a diagnosis of lupus from this, and so often in these you have to do a little skin biopsy to see what's going on. There are just some pictures here of these various conditions. Actually, let's just have a quick look at granuloma faciale, see if they've got a decent one here. Not really. Let's look at this one. There's that plaque there. Has that got peau d'orange appearance? not really. Often they're a lot more raised than that, and certainly the more raised ones have a podoronge appearance. I mean, you'd need to biopsy that to see what was going on underneath. I think there was a histology there that I just wanted to show you, that Gren zone. Let's go for this one here. It doesn't really, you can see most of your inflammation is in this area down here. There are sometimes some eosinophils involved in granuloma faciale. That's the little area of a Gren zone there, a sort of clear area underneath the epidermis itself. Okay, lumps in the gums. We don't see a lot of that. We don't see a lot of oral lesions. But I've said to you the differential diagnosis includes giant cell granuloma, peripheral ossifying fibroma, and epulous and pyogenic granulomas. Let's look at epulous. It's usually any benign lesion situated in the gingiva, but you can get them as congenital, and they can be acquired. Most of these are reactive processes with varying degrees of fibrosis, inflammation, and vascular proliferation. Let's have a little quick look. There's an epulous there, usually on the gingiva. They can be present at birth, they can be acquired. They're benign fibrovascular proliferation. I think we have a quick, sure we had an example of it here. Did we have that here? No, we didn't, sorry. I thought I had a little picture of, yeah, I think it was here. Here we go. Congenital epulous. Benign soft tissue growth arising exclusively in newborns from the edentulous alveolar ridge or palate. Most commonly anterior maxilla, as in that example I just showed you. 10 times more likely to occur in females than males. That's interesting. Soft pink fleshy growth, compressible. Prominent telangiectasia. Base can be pedunculated or sessile. Generally they should be excised. Numerous granular cells may be seen. Multiple lesions are present in 10% of cases. I think we had some little pictures. We have a picture here. Yeah, there's one. There's a congenital epulous of the newborn. But as I say, you can get acquired ones as well. Okay, juvenile xanthogranuloma. We talked about this as being one of the histiocytoses, but the non-Langerhans cells histiocytoses. They generally present as solitary yellow or yellow-red nodules like this. Occasionally you'll get some multiple ones. If you've got multiple ones, it can be of more significance. Always get the eyes examined by an ophthalmologist because you can get the xanthogranulomas in the eye as well, especially if you've got the multiple ones like this. Differential diagnosis for solitary juvenile xanthogranuloma can be a spitz nevus, because some spitz nevi are pink like this as well. But I suppose really you might think of a mastocytoma, but usually they're much flatter and bigger than this sort of lesion. So we've said that juvenile xanthogranuloma is a benign xanthomatous and granulomatous disease of the skin, mucous membranes, and eyes. Can occur in crops, usually for 6 months of life. Lesions vary in size there. Sometimes there's an association with neurofibromatosis. And the thing is, occasionally patients with multiple juvenile xanthogranulomas may develop a myeloid leukemia. So if you've got a child, you want to just examine them carefully and have a blood test done. Fats are normal. And any eye lesions that do develop are usually benign. But 75% of cases are solitary juvenile xanthogranulomas, and you don't need to do anything specific for those. There's the other type of histiocytosis called xanthoma disseminatum, usually seen in males between the ages of 5 and 25, yellow-brown papules in the flexures, normal lipids. 40% of people who have xanthoma disseminatum have diabetes insipidus. That's just something to remember for an MCQ. Pilomatrixoma. In children, if you're looking at benign tumors that they may get, I think 60% of the benign tumors you're going to see in children are going to be pilocysts. 20% are going to be pilomatrixomas, and the other 20% are going to be a mixture of a whole variety of things. Pilomatrixomas, usually in children, usually on the face and cheeks and forehead, very hard, stony hard, occasionally lobulated. They're never malignant. So you'll see the child who'll come in with this lesion in the face, and you'll think initially that this is going to be a pilocyst. But when you feel it, it feels very hard. And that's because there's calcification within these things. And if you look at them histologically, you've got these dark staining basophilic cells peripherally, eosinophilic cytoplasm in the middle of the lesion. You may get calcium or bone formation. This is a picture here of a pilomatrixoma. This, you can see, looks cyst-like. This is a bit more lobulated. If you stick a dermatoscope on this, which is what's been done here, you can see that these little nodules that you're seeing here come up as white like this. So these white areas here correspond to what we're seeing here. And this structureless white on the dermatoscope represents the calcification in the dermis in a pilomatrixoma. White structureless areas can also be seen with mollusca, and I think they can also be seen in accessory nipples with a dermatoscope. But you know, white structureless like this, hard, firm, lobulated lesion, solitary lesion, pilomatrixoma. Generally, I advise excision of these. They don't resolve on their own. There is an inherited version where you can get multiple pilomatrixomas. What about Spitz-Nevi? We should have had a picture of that. They're usually rapid growing nevi in children. Now, half of them can be black in color, half of them can be pink or red in color. And the problem is the histology is very suggestive of melanoma. The fact that they grow so rapidly is the thing that's quite worrying. There are very definite features with a dermatoscope that can help you, and we'll come to that later when we're dealing with dermatoscopy. Generally, you can have what's called a starburst histological pattern where you've got peripheral clods, generally much the same size all around the outside of the lesion, and it's pretty symmetrical. Okay, what's the next one? Epidermodysplasia verruciformis. Well, that's not a common condition. It's a papillomavirus problem. There's some oncogenic variants of papillomavirus involved in this disorder. There's inherited variants of this as well. And some of the oncogenic papilloma types can give rise to carcinoma. So clinically, they're going to come across as flat, plain wart-like lesions on the face, or perhaps on the body as well. They may be verrucous elsewhere. I've said that 20% may develop a squamous malignancy, usually on exposed areas of the skin. In other words, it needs the papillomavirus plus sunlight to induce that malignant change. Differential diagnosis, acrokeratosis verruciformis, usually acral, warty-like lesions, similar to those that you see in Darius disease. We said this might be a form frust of Darius. We said epidermodysplasia verruciformis is inherited as an autosomal recessive. The HPV types involved can be those that are seen in normal hosts, as well as some types that are unique to this condition. And these patients seem to have a defect in cell-mediated immunity. The condition usually presents in childhood. As well as papules in the peripheral areas on the trunk, there's sometimes red plaques or hypopigmented, very slightly scaly plaques that may resemble tinea versicolor. I think there was a case at Skin and Cancer many years ago that people felt was tinea versicolor, and the diagnosis of epidermodysplasia verruciformis was properly made. And the other thing here, if an SCC develops in this condition, radiation therapy is contraindicated and surgical treatment is best. I think we might have a decent picture here of epidermal dysplasia verruciformis. Let's have a quick glance. This is from dermis. Yeah. I mean, if you were looking at these lesions, you'd say they're plain warts, wouldn't you? But if you had really, you'd expect a few plain warts maybe in the face or maybe in the back of the hands. If you've got someone covered in these, then you've got to consider that they may have this condition, epidermal dysplasia verruciformis. And 20%, as we said, may have oncogenic types of papillomavirus that may subsequently go on and develop SCC. So that's the significant thing about it. Okay. Next thing, atypical fibroxanthoma. AFX, atypical fibroxanthoma. You're going to see this in the elderly. It is a tumor, particularly of the head and neck. It generally, this isn't the greatest example, but it generally looks like a poorly differentiated SCC. It can be quite vascular on the surface. In fact, it may ulcerate as well. It's usually you usually diagnose SCC clinically, and it's only when you do a biopsy beforehand that it has the characteristic histopathology with lots of changes in the cells. There's often a lot of giant cells. There's a lot of atypical nuclei there. Some giant cells are in fact seen. And it looks a lot more aggressive than it actually is. It doesn't usually metastasize at all. It typically will be a localized lesion that you should just treat as a poorly differentiated SCC and put 5mm margins around it when you're doing an excision of it. Yeah, I've said that it's sometimes misdiagnosed as pyogenic granuloma. Why? Because of that red vascular sort of surface. Often on the lips, face, and neck of an elderly patient. Necrobiotic xanthogranuloma. Now, you might have heard of necrobiosis lipoidica, that curious lesion that occurs in the anterior shins and is seen in diabetics. Either, if they haven't got the diabetes, most of them will subsequently get it. So I think about 80% of patients who have necrobiosis lipoidica will have diabetes. But there's another thing, necrobiotic xanthogranuloma. Now, this condition, here's a picture of it anyway. Yeah, if you were to transfer that to the front of the shins and show it to anybody with that yellow background and superficial telangiectasia, then they'd diagnose it as necrobiosis lipoidica. And there is this phenomenon of apparent cell death in the dermis with abnormal collagen there and and cells coming in round that abnormal collagen. Your histological differential is going to be granuloma annulare. The thing is, in necrobiotic xanthogranuloma, they often have eye lesions as well, involvement of the conjunctiva, and the thing about them is that they often have an underlying myeloma or a myelomatous protein. So check Benz-Jones, do immunoelectrophoresis on their blood because they may have that. I've said older adults, periorbital plaques and nodules in about 80% of cases, so often periorbital. They may resemble xanthalasma. So you might think there's xanthalasma looking at the eyelids, but they're much deeper, firmer and indurated, and they extend into the orbit. The trunk may have plaques that are similar to necrobiosis lipoidica, red in color, atrophic center, superficial telangiectasia. And these are the other eye features that you may see in this condition. I think I'll subsequently show you a case that I saw where the guy presented with these various eye things plus a skin lesion. And at the time he said to me, he said, "Do you think my eye problems are related to what I have in my skin?" And I said, "No, don't really think so. It must be something separate." And it was only after I did the biopsy and the histopathology showed that I soon realized that his eye problems were relevant. So other eye things you can see, keratitis, uveitis, neuritis, and there's usually a paraproteinemia with them. I don't think that image diagnosis case will come up. Maybe, let me click on this. I haven't tested this link. Ah, here he is. There was my man there who presented, here we go, a lesion on his abdominal wall, which was yellowish and slightly atrophic. Yeah, he asked me if his eye problem was related, but I said no. The eye features were very relevant when I did the biopsy. What does he suffer from? Let's have a little glance. You know, it's quite subtle, isn't it? You know, you would sort of say he's maybe got some form of conjunctivitis, but if you look here, there was thickening of these eyelids. You know, there was obviously something else going on there, and I wasn't savvy enough at the time to pick up what it was. But this was necrobiotic xanthogranuloma. You'll come across this guy in the image diagnosis section at some stage. Pemphigus vegetans. Well, if we put that up, this is like Pemphigus vulgaris, but the edges of the blisters develop hypertrophic features. Remember, pemphigus is where you develop, it's not immune disease, you develop antibodies that attack the desmoglein proteins, either desmoglein 1 high up in the epidermis near the sternum granulosum, and that's the protein that's attacked in pemphigus foliaceus, or else desmoglein 3, which is a bit deeper in the sternum spinosum, and that's the protein that's attacked when you have pemphigus vulgaris. Remember, the desmoglein proteins represent the desmosomes that hold the keratinocytes together. And so if you've got an immune attack and these keratinocytes just fall apart, so the epidermis falls apart. So you may get fragile, thin-walled blisters, and then you'll get crusts on the surface. And the patient's going to present mainly with crusts. But in pemphigus vegetans, particularly you'll see this in the scalp, they get a lot of vegetation, they get a lot of thickened crusts. And this variant is seen particularly around the mouth, the anus, and the vulva, also in the flexures. It can be seen in the scalp as well. So we saw pictures of pemphigus vegetans later on. Tough diagnosis to make as well. You know, you just don't expect it. You think that it's some form, if it's just, because often it's a localized area, and it looks like some form of impetigo, you know, a blistering impetigo. It looks like a staph. You'd expect staph infection there. But it doesn't respond to antibiotics and your usual staph treatment, and so you ultimately do a biopsy, and it's the biopsy, even the ordinary histology without the immunofluorescence, that shows that it's pemphigus vegetans. What have we got here? Geonotic Krusty. Geonotic Krusty is a viral exanthum seen in children, and it's the distribution of the rash that's so characteristic of this particular condition, because it's essentially extensor surfaces of arms and back of hand, extensor surfaces of lower legs and feet, and typically also in the cheeks. And there's not much in the trunk. And it can be due to a variety of viruses. It was initially described by Gianotti and Krusty in relation to, I think it was hepatitis B. I think it was B rather than A. And, you know, some of these kids had jaundice and had to be looked at. But generally, in this country, we see it with a variety of viruses. And it can occur with Epstein-Barr. It's probably the commonest one that we'll see it with. But we don't necessarily go investigating these kids. We know that the condition's just going to resolve. This is a picture of a child with it, fairly subtle, just red non-scaly papules, generally on the back of the arms and the extensor surfaces of the legs as well, extending to the back of the hands here, but the trunk's clear, and it's often seen in the cheeks as well. It used to be known as papular acrodermatitis of childhood, which may be a better name because it best describes what you actually see. Initially it was the hepatitis viruses, but Epstein-Barr I think is probably the most common one that we're going to see here. Median age for this condition is 2. The lesions are erythematous papules or papulovesicles, symmetrical face, buttocks, extensor limbs sparing the trunk. I said, note, this is in contrast to most viral exanthums, which usually involve the trunk, and there may be some associated lymphadenopathy. It may last 1 to 2 months, so, you know, you've got to be confident of that sort of diagnosis. You know, if you say to the mother, oh, it'll just go in a week or so, well, might not. Might going to last a lot longer. But it's the distribution that'll tell you that it's geonotic Krusty. Then I've come to here, nearly the end. Skin rashes of infectious mononucleosis. They can be measles-like, scarlatiniform, maculopapular, urticarial, purpuric, because you can get thrombocytopenic. Or, there's that ampicillin-like reaction when amoxicillin or ampicillin is given to someone who's got sore throat due to glandular fever. They get this amoxicillin rash. That's a maculopapular measles-like rash. Doesn't mean that they're allergic to other penicillins, by the way. But you can get a variety of rashes from the Epstein-Barr virus, and you can get zoonotic Krusty as well. We've said here other skin lesions, the zoonotic Krusty. Chronic active EB virus is rare. Two unusual skin eruptions described include a granuloma annulare-like eruption, chronic erythema multiforme-like rash. Yeah, that's the condition that I think you should associate with Epstein-Barr, and that's oral hairy leukoplakia. It's an acquired white lesion in the inside of the mouth, particularly along the sides of the tongue, strongly associated with EBV in a patient who has AIDS. So commonly seen in AIDS patients. Can also occur in other immunosuppressed hosts, especially kidney and bone marrow transplant recipients. And then the torch syndrome. You'll see that this stands for a variety of viruses that may cause this condition. Seen in newborn infants, some have blueberry muffin lesions. Now, blueberry muffin lesions are blue lesions in the skin in a newborn, and they represent cutaneous hematopoiesis. And these kids often have hepatosplenomegaly, jaundice, and purpura. And various viruses, including cytomegalovirus and infectious mononucleosis, can cause this torch syndrome of blueberry muffin. I think we've got a picture. Here's a picture down here of a kid with the blueberry muffin lesions. There's a bit of hemorrhage. This looks purpuric. These are a bit more bluish looking on the face. You don't want to see that in a newborn. Okay. We ended up with a few, oh, by the way, let me show you this picture here. This was the ampicillin rash. Someone who's got glandular fever, and unfortunately you don't diagnose it properly, and you go and give them amoxicillin, then this is the sort of maculopapular rash that they may get. May even look urticarial at times, but of course the individual lesions last longer than 24 hours, so it's not a pure urticaria. But this is the sort of rash that they may in fact get. These were just a few little questions at the end. You can, in fact, probably have done them yourself. Are the nails thickened disc keratosis congenita? No, they're thickened pachyonychia congenita. Lymphocytoma cutis is usually found on the central face in older males. And the answer to that is certainly on the central face. It can be in older males. Remember, often on the earlobes as well. What two conditions may be found with juvenile xantham granuloma? Well, neurofibromatosis you look for. So look, see if they've got any pigmentation of crow's sign under their axillae. Look, see if they've got 6 or more capillary spots. And also a myeloid leukemia, so you might need to do blood tests if they've got multiple juvenile xantham granulomas. You've got to check the eyes as well, remember. Diabetes mellitus is a feature of Xanthoma disseminatum. No, it was diabetes insipidus, defect in ADH, antidiuretic hormone production. So, I can tell you, these were fairly esoteric things that are in the first of these tutorials. I don't know why we, Ken sort of had us looking at this in such detail so early with these conditions. The thing was, though, that we had a variety of registrars there from first year right through to fourth year. And third year at that stage, sorry. And I think he had to have things for everyone. Now, I promise you the rest of these tutorials aren't quite as esoteric as this one has been. But I just wanted to give you an introduction to a variety of unusual conditions. You're not going to see these much at all, but it gives you an idea of the depth of dermatology, the wide range of things that as a as a registrar or as a consultant, you have to have some sort of knowledge of. You're not going to see these conditions frequently at all, but you should, when you examine the patient, note certain things, and hopefully it'll trigger a few memories there that would make you consider some of these other unusual conditions, or at least send you scurrying to the books to look some of these things up. We'll come across a lot of these conditions again as we go through these various tutorials, so don't think this is going to be the one and only time you're ever going to come across these. Thanks very much.